for today. The title is Operationalizing the Evidence, and we're honored to have our guest presenters, Bryan Wilson and Sheree Murphy from NEMSQA, and they're going to provide an overview of the importance of pre-hospital care in post-MVC outcomes and alignment with national priorities for improving post-crash trauma care, the process for identifying and development of measures, which includes the methodology for scoring and ranking measures, and the rationale and importance of the measures developed and future considerations. So with that being said, I'd like to turn the time over to Bryan. Thank you so much, and go ahead and take it away.
Good afternoon, at least here in Pennsylvania. It's great to see everybody this morning. As so kindly introduced, my name is Bryan Wilson. I'm an emergency and EMS physician in Bethlehem, Pennsylvania. I'm also the co-chair of the Measure Development Committee and recently elected as the Secretary Treasurer of NEMSQA. And it's my privilege to be here with our esteemed Executive Director at the current moment, Sheree. And so, Sheree, say hi. We're going to talk to you today a little bit about a very fun project that we got to embark on, focused on post-crash care and the development of some quality measures around that. And I'd be remiss if I did not acknowledge our colleague Jeff Jarvis, who is on the board with us and also served as the co-chair of the technical expert panel when we developed these. And so Jeff supposedly is going to jump in at some point. But I just wanted to give him credit for his thought and process into this. So without further ado, we'll jump in. So our goal, right, with NEMSQA, right, the National EMS Quality Alliance, the idea here is to improve patient outcomes through collaborative deployment of quality measures for EMS and healthcare systems, right? We're trying not to limit ourselves only to EMS. We want to try to include as much of the healthcare system as possible. But at the moment, we align very closely with NEMSIS and trying to find ways to operationalize and use the NEMSIS data set for ways so that we can measure and describe our performance. And we're going to talk a little bit about that today. And so, next slide. Right. This project, Post Crash Care, came as a grant from the from NHTSA, right? And we worked with the Office of EMS as we tried to figure out what exactly we wanted to do here. And particularly, it's under this third element of the mission that they have in the office, right? Which is to assess, plan, develop, and promote comprehensive evidence-based EMS and 911 systems. And that's what we were really focused on with this one was how do we both reduce road disability and then help provide some of that information back to OEMS so they can do that leadership that they talk about. But we really kind of dove into that third part of the mission in what we did here with this project. Next slide. Great. So if you've been around quality long enough, you've heard this saying, right? Show me what you measure, and I will tell you what you care about. In quality management, what you look at, what you try to measure in your system says a lot about what's important in your system. And what we noticed is that kind of across the board, there wasn't a lot of information out there about what we should be measuring in post-crash care patients, right? In these trauma patients, what are some of the important things that we want our pre-hospital clinicians doing in order to try to do that? So we didn't know what was important. We didn't know what to tell people. So we had to try to figure it out. And that's kind of where this came from. So we're going to tell you what we think might be important here, but also give you an idea of some of the opportunities that we identified during this project. So a little bit of background, right? Why does this matter? Why is this important? Okay. So we know that there were over 1.4 million crashes, right? That we had 5,400 PSAPs that dispatched EMS to. And in that, we had about 165,000 severely injured Americans that were treated by 12,000 EMS agencies. We've shown before that timely on-scene care saves lives, right? And that longer response times over 12 minutes were associated with higher mortality than shorter response times defined as under 7 minutes. If you were in that 7 to 12 minute, congratulations, you're our reference time period. We don't know what to do with you. But the over and the under, we found that difference. But much like we've seen across the realm of EMS, where we've gotten away from talking about time, because time is one of those variables that we unfortunately uh, can't impact a lot in a state of readiness that becomes affordable. And while it matters in a subset of populations, there's also a larger set of populations where time is of less importance, right? And there are other interventions that are more important. So we want to look beyond time to try to find ways that we can improve this gap and save more lives. And we're going to talk about the gap here on in a coming slide. But what we found was that post-crash care opportunity was really the last thing to be able to make an impact on the morbidity and mortality. As we know, our cars are much safer than they were in the 70s and the 80s, right? Between seatbelts, crumble zones, airbags. Unfortunately, I was in a car accident versus a deer back in 2024. And I had a BMW at the time. And man, I hit that deer and I ended up in a cocoon of like white, cushy airbags that just like kept me in place. And I didn't feel anything other than sorrow for my lost BMW. But that was, an awesome thing because next slide. What we know is that there are a lot of people that die at car accidents, right? A lot of people die alongside the road. And what's actually shocking is that 2 out of 5 of those who die in car accidents are actually alive when the first responders get there. So our first responders get there and they have a live patient, but unfortunately that person does not survive. Now, we all understand that there is this um, this idea of in my shop we call it a plucked flower. There are some patients whose injuries are so severe that they can't survive even if they're alive for us, right? And we acknowledge that. We acknowledge that there are some patients that unfortunately modern medicine just does not have a cure for. However, there are a lot of patients who are severely injured that if we could have just intervened a little bit sooner, we would have had an opportunity to save that life. And that's really what we're talking about here, right? We're trying to figure out how can we reduce 40% of deaths at the roadside at a crash site. How can we reduce that to a lower number? If they're alive when we get there, there's obviously an opportunity, and we wanted to kind of dive into that to try to understand where we could move the needle and save the most lives. Next slide. And so when you think about the chain of survival, right, we know about this from cardiac arrest. We've seen this time and time again. Here's that chain of survival when it comes to post-crash care, right? We have the initial call intake, right? 911, the dispatch, the bystander care. What's the information that we're giving over the 911 line, right? And then we look at that timely on-scene care. We look at that appropriate triage and transport to the appropriate trauma receiving hospital, right? And then we look at that definitive care at a trauma center for knowing what we want to be able to I'm sorry, we look at that definitive care at a trauma center, knowing that that's where they're going to have that biggest opportunity to save lives. But the question here is really, where does EMS fit into this picture, right? Because we are the EMS Quality Alliance, right? We're not the American Healthcare Quality Alliance, right? But how do we help be a very supportive link in that chain? Next slide. Right. And so that's really what we took a look at here. However, what was very interesting when we kind of started on this post-crash care endeavor is that um, this is not a easy subspecialty, right? There is not a house of medicine that I can turn to say that, oh, post-crash care is just this, right? STEMI is easy, right? That's cardiology, right? That lives right there. We have the AHA, we have those guidelines, right? Post-crash care, while it lives under trauma, absolutely, it's part of that trauma care, right? It's a subset, right? Post-crash care victims can be penetrating trauma or they could be blunt trauma. We don't know, right? It could be both, right? They could have been in the car crash, ejected from the vehicle, and then impaled on an object. Unfortunately, I think we've all seen something that crazy to know that that's a challenge that we have to overcome. And because of that, there's not a single document or guideline that we can go back to look at. And Sheree's going to touch on why that's important when she goes through our process so everybody can understand how we got to where we ended up here. Right. As we talk about survival, right, we fundamentally that's what we want, but survival is really, really hard to measure with the NEMSIS data set and what we currently have available for EMS data. And so it's a huge opportunity going into the future of how we can improve the data that we have available to us. There is one systematic review that we were able to find that was published somewhat recently from our colleagues in Australia. So we thank them for their work that kind of looked at opportunities, right? Interventions and post-crash care that we might be able to do. But that was kind of it, right? So we had to convene a technical expert panel to really look at all the different things that we know from all the different, interventions that we can do to try to save lives. And so I'm going to turn it over to Sheree here, who's going to talk to you a little bit about our process of how we develop the measures that we develop so that we can actually show you what we came up with.
So sorry. Oh, I never changed my name. I am National EMS Quality Alliance. So Brian walked us through sort of the background and the theoretical of what we were trying to accomplish, and I'll walk you through the nitty-gritty details on how we got to our end result, and then I'll turn it back over to him to talk about the measures that we developed in a bit more detail. So I'm not going to go over this entire measure development process diagram. Just want to point out generally the overall framework is kind of three phases. One is measure concept identification. Then we have our measure concept prioritization, and then we have our measure specification. Or in maybe, layman's terms, we might call this what could we measure, what should we measure, and then how do we actually measure it. So when we look at the first sort of entry point in this process, we're looking at receiving new measure concepts or new ideas on what to measure or, what we're going to measure in our end result. So there are really three ways generally that NEMSQA might receive what we call a new measure topic. It might be a call for concepts, which is basically asking a group of people. It could be the general EMS stakeholder community at large. It could be a specific group of special experts on a certain clinical area. Um, and they just offer ideas on what would be important for EMS to measure. There's also this fairly new process that we developed in partnership with Pre-Hospital Guideline Consortium, which I'll talk about in a few minutes, which is this idea of an evidence-based guideline-derived measure topic. And in that, what we would do is we would take an evidence-based guideline document, which is that synthesis of all of the research that tells us what we should do or how we should treat this certain, group of patients, and use those to identify ideas for what we could measure. And then the other opportunity is that we understand we're not the only people developing measures in the healthcare ecosystem here. So there may be other organizations or entities that have developed measures related to pre-hospital care. And so there's also the opportunity that we might have a call for or just invite a specific entity to submit their measures to be endorsed by NEMSQA so that we kind of have that full picture or like clearinghouse of these are the things that are important to measure and to ultimately improve in order to improve outcomes for the patients that we treat. So this particular project, like other projects, ends up being sort of a little bit of a hybrid approach. For this particular project, we were really aiming to use the evidence-based guideline approach because, like I said, we have this collaboration with the Pre-Hospital Guideline Consortium, who's identified a lot of pre-hospital evidence-based guidelines that could be fodder or food for, identifying things that we could measure, but also seeing as though we had put together a group of experts in the area of trauma, we also asked that group if there were ideas that they thought we should measure in this space. And most of those actually, we were able to align with the guidelines and the recommendations within that we identified. Um, but we also did do sort of that call for concept among the technical expert group. So what I want you to gather from this slide here is, like I said, there are a lot of guidelines that get published out in the cyber world. Um, and we're really fortunate that the Pre-Hospital Guideline Consortium has a process that they go through every 2 years where they do a systematic review and search for any guidelines that are related to pre-hospital care. And they actually review those guidelines and score them for the quality of those guidelines because not all guidelines are created equal. I mean, literally any of us could probably go and create a guideline, but there are certain criteria that make a high quality guideline. And so they review these guidelines to that criteria and literally like score them. So what we've chosen to do in our process is that we take the guidelines that they have reviewed and only include the ones that they've identified as being high quality guidelines or meet the National Academy of Medicine criteria. So what that's looked like is they've done this since 2020. So actually 2026, there'll be one coming out shortly. Um, so what this looks like is 2020, 22, 2024. You can see that line up. They reviewed 71, 75, and 33 evidence-based guidelines. Of those, 28 from 2020 and then 14 and 10 moving down the line were related to trauma or pain. We kind of put pain into the trauma bucket. But of those 28, 14, and 10, we excluded some that did not meet National Academy of Medicine criteria or were not deemed to be high quality guidelines. That ultimately left us with 17 evidence-based guidelines from which to identify potential things that we could measure related to pre-hospital trauma care. I will point out that between 2020 and when we did this project, the CDC trauma triage criteria were updated to the American College of Surgeon criteria. So we ended up excluding the CDC in favor of using the more updated version. So what that means is that in the end, we reviewed 16 evidence-based guidelines. And what I want you to see from this is like, yeah, that was 16 documents, but within those 16 documents, there are a lot of recommendations around how care should be provided. So, how many? Well, from those 16 documents, we identified 325 individual recommendations. If you're used to looking at these guidelines, it specifically says for this patient population, you should do X, Y, and Z. There were 325 of those recommendations regarding trauma care. So rather than bring all 325 of those to the expert panel, we do a simple first round review where our measure development co-chairs review those recommendations and really just exclude the ones that either are not ended up being relevant to pre-hospital care, are related to structure or research recommendations, which we don't, really create measures around right now, et cetera. And so what happened is that, reduced that 325 to 119 individual recommendations that we moved to the next phase of the process, which was to identify the measure concept or the idea of what could be measured. And so this is where that technical expert panel consisting of representatives from all of our national EMS organizations, different specialty societies, our federal and state agencies and partners, the Department of Defense Joint Trauma System, to really look at these and identify what we could measure in post-crash care trauma. And so what that resulted in was identification of 60 potential measures or measure concept, measure ideas that could be developed. What we then did was we grouped those into clinical area because, like Bryan said earlier, when we're talking about trauma, like we actually did a project just on airway. Well, airway is part of trauma care, and there might be specific recommendations around how you manage an airway in a trauma patient. So we had to look at all of these clinical areas. And so, in order to kind of, there was some overlap and duplication of recommendations between different sources in these areas. So, we kind of grouped the recommendations together just to make it easier to think through what we could measure in this space. Because the last systematic review, we understand that guidelines are being continually developed, and there's a 2-year gap between systematic reviews. And some individuals from our technical expert panel also recommended that we look at the trauma compendium um, components, whatever the right word for that is, because there are different pieces of it from NAEMSP. And so we did include in this the trauma compendium on pneumothorax and entrapment. We didn't use those as primary source, like we needed the guidelines that we reviewed to include a recommendation around that. But when we got into the details of what that measure might look like, we also referenced the trauma compendium. So we did have some additional recommendations that we added in there, as well as the expert panel submitted concepts. And so, what we then do is those 119 recommendations got filtered down into 60 measure concepts, and they were, so again, we can't develop 60 measures. Nobody wants to measure 60 measures, and you wouldn't know where to improve. So, what we did was we go through a Delphi-like process. First, all 60 of these measure concepts get scored by each member of the technical expert panel in 4 of these 5 categories. We don't have everyone who's reviewing the measure concepts score evidence because by and large, that level of evidence is provided within the guideline. And so just one score for evidence is provided for each concept. But for each of the other 4 areas, clinical value and impact, feasibility, face validity, and technical work and implementation, each person on the technical expert panel will score those. And you can see, I'm not going to go into detail just based on time, but you can see what the point values are that folks can assign to this category for each of those measure concepts. We broke this up into 3 different surveys because if you do the math, 60 measure concepts and scoring 4 categories basically equates to, if I do my math correctly, 240 questions essentially. So, in order to kind of eliminate the survey fatigue, we did break this up into 3 surveys. So, we did like, airway, uh, and some other pieces as like one survey, and then broke them up accordingly. So, when we finish this process, this does not include all of the measures. As you can see, that's not 60 lines there. But just so that you get an idea of what this looks like is once we finish that, we take the sum of the mean for each of the categories or just the score, like evidence, face validity, just get a score. And those get added up so that each concept gets a total score. So it's a very objective process. Um, and what we aimed to do was to take this objective data, like the score that each of these concepts received, and using this as the basis for conversation, come to consensus on the top 25% of measures that we would then move into a second round review. We came really close, and we ended up moving forward 17 concepts as opposed to our target 15. because there were a couple of measures that didn't really score in our top 25%, but we got consensus from the committee that these were important priorities to move forward into our next round of scoring. So we got 17. I was actually pretty happy with that. So then our second round with those 17 measures had the expert panel do two things. Is one, they rank ordered the measures, and then they gave each measure a priority um, rating, one being highest priority and five being lowest priority. And so then what we did was this was a little bit, might trip up your mind a little bit. So let me just explain this quickly. So we took the mean of the concept ranking and the sum of the concepts, each individual concept's rating score, and added them together to get their like round two score. So now in round two, lower is actually better than higher. So just flip your framework on this one to think lower is better. And so this is the result of, the objective rank order list of the round two results of the scoring criteria. So again, same process, putting this through consensus discussion. We ended up identifying these measures as the measures that we were going to move forward into development. One of the things I will say, because I'm sure it's like an obvious omission here, is why is pre-hospital blood administration not included on this list? So it was discussed as one of the measures that would be considered to be developed. But at the time that we were going through this process, NHTSA was also in the cycle of doing their, I'm going to probably use the wrong word, but a similar, like a systematic review on the evidence around blood. And so the decision that we made at that time was we didn't want to put something out and then have to change it or make it different based on whatever the results of that um, review might be. So we decided to pause on that and wait for the results of that to come out, just because I know that might be a question. So then what do we do next? We take these ideas and we apply the NEMSIS data standard to them. So we look at the elements within the NEMSIS data standard and say, okay, how do we use these discrete variables to identify the population that we are looking for to be treated for these conditions? And then how do we determine that those either assessments or treatments or whatever it is that we're looking at were performed for those patients? And we go to the NEMSIS data standard in order to do that. So sometimes it's challenging we may not have the discrete data that we need in order to find a specific population or determine their eligibility for something. It may be something that you would be able to do by just looking at the patient record, right? You're like, oh, obviously this patient needs a tourniquet. But to be able to identify that using just the discrete data variables that we have in NEMSIS presents us with this really fun puzzle that the committee then works through, and in the end comes out with this really prescriptive document, our technical specifications, that tell you exactly how to find these or identify these patients, and how to find the treatment or the care that we're looking for them to receive. So, again, this is duplication. These were our final measures, but I'm going to turn it over to Bryan to kind of walk us through those details of how did we end up defining this sort of idea of, did you apply a tourniquet?
Right. Thank you, Sheree. So as we look at all of those measures that oh, my camera just died. Sorry, everybody. Let's see. There we go. So as we talked about how we looked at all of these measures and how we kind of brought them all together, the one thing that we agreed upon is we wanted to make sure that we were pulling for the same initial population, right? The same pool of people is what we were looking at when we were trying to divide them up and evaluate their performance under these quality measures. So we used basically E-injury O1 and E-injury O2 as the main defining features for our measures here. And the first one was cause of injury. And then we used basically what you're seeing here as outlined, and I have to move my box. The patient was an occupant in a motor vehicle accident, etc. Motorcycle rider, pedestrian rider, pedestrian injured in a motor vehicle crash, and a few others. And so our technical document specifies all of that. And then E situation O2, which was the possible injury equals yes. And so we're looking at those two elements to define that initial population, which again is where we would start looking at for this. Next slide. And so we're going to take a moment to run through each of these quality measures that we have, just to kind of give you an idea of what our numerator and denominator was, with an understanding of this is the pool that we're looking into. So PCC-01 is the clinical assessment of patients with a TBI. And so our numerator is all EMS transports, right? So not non-transports, people who went to the hospital, who had a pulse ox and systolic blood pressure that are assessed, and if they were getting any type of artificial ventilation, so whether it was manual, like BVM, they were intubated, iGel, ventilator, whatever the case may be, whether or not they had an end tidal assessed. And the denominator in this was the patients who had a suspected TBI. So again, we looked at suspected TBI as E-vitals 23, right? So a GCS of less than 15, or they were less than alert on the AFPU scale, and they had some type of diagnosis, either primary or secondary, that would be consistent with that. And we wanted to try to, obviously avoid the unconscious person bleeding to death, right, who may not have a TBI because they just have, an isolated, abdominal injury, and they're bleeding that way. And so this is how we tried to get around that. One thing that I will say real quick, should we just go back to the PCCO1 slide? One more. Is that we actually use the learning that in our discussions from our experts in this one, and Jarvis talking with Dr. Doug Kupis as well, that we're actually proposing changes based on PCCO1 to our standard intubation measure that we have out, that's not just for trauma patients, based on this artificial ventilation and tidal measurement thing. So more to come on that, but it was nice to see the PCC stuff kind of bleed out into our larger work. All right, we can go back to O2. So PCC O2, we looked at monitoring of pulse ox and SBP for TBI patients, right? And so again, this was EMS transports during which an SpO2 and SBP are monitored or documented at least twice. And the denominator here is patients with suspected TBI. So let me give you a little bit of backstory with this one to try to understand. The TEP unanimously agreed that we want continued monitoring of these patients, right? We understand the importance of watching these critically ill patients from beginning to end during our care to make sure that our interventions are continuing to have improvements and that the patient's not deteriorating. However, we had a lot of struggles verifying what monitoring would be in the NEMSIS data set. And if you take a minute to think about that, how do you at an EMS agency level know whether or not there was monitoring done, right? You can go back in the attachments, you can look at the file, right? Were they hooked up continuously? Were they not? We don't have an easy way of doing that using just NEMSIS data at the level that we were operating. So we acknowledged and took the opportunity to say, well, if they at least had two documentations of these vital signs, that they probably were monitoring them continuously, but at a minimum, they did at least multiple assessments. And so that is some type of monitoring. So we do acknowledge that there's an opportunity for improvement with the NEMSIS data set to help maybe better define how we monitored somebody. But that's kind of how we ended up with this one here of it being at least twice.
And I'll add to that discussion if you're sitting there thinking, oh, well, this seems easy. If we say monitoring is you should have these documented every 5 minutes, why can't you just do that? That seems mathematically pretty easy to do. Well, then what happens in those instances where you may have gotten that, you either did it manually or your monitor is set to do it every 5 minutes, but the documentation that gets pushed into the chart is actually 5 minutes and 2 seconds. Like, then you miss doing it every 5 minutes because you're outside that window. And so it just becomes very complicated mathematically to figure out how you're going to do that. And then we also ran into the different lengths of transport times and how many times that would need to be done. So I just want to point out, because I would probably be one of you sitting here saying, well, it seems pretty easy. You could just look and see if it was done every 5 minutes. When you actually go to put that into operation, and this is where the testing with Alyssa Green, who's doing this testing, like it seemed pretty straightforward when we suggested to her what we wanted to do. And then she came back to us with questions that was like, well, actually, what you think is really straightforward, I'm actually not sure what to do with. Do you want me to measure it this way or do you want me to measure it this way? So, what seems simple becomes very complex. So, if you enjoy that kind of thing, join us in putting the puzzle together. Sorry, I just was like, people might
Yeah.
be sitting there thinking this is super easy and without knowing like some of the attempts that we made at defining it in a different way and the challenges that were faced in what to even us as the TEP seemed pretty simple and straightforward, ended up not being very simple and straightforward when you actually try to operationalize the idea.
Yeah, and I had actually forgotten about that. So thanks for mentioning that, Sheree. I remember when Alyssa came back with that, and all of us kind of sat there and we're like, "Huh, okay, yeah, no, this hadn't considered that." So yeah, if you have good ideas, right, or suggestions, we welcome fellow nerds to join us. So please come be part of the team. Cool. All right, we can go to the next one. There we go. So PCC03 was end-tidal capnography monitoring in invasive airway. And this one obviously has a lot of face validity, right? So these were anyone who had a successful invasive airway, so whether it was supraglottic or endotracheal tube. And we were looking at the numerator being end-tidal values documented at least twice, and at least one associated value of greater than or equal to 5. And that had to do with uh, published evidence of needing an end tidal value of greater than 5 to actually show confirmation of airway placement. So Jeff had actually been responsible for that information, which was great. So this was pretty easy and straightforward one that we came up with. Next slide. PCC04 was the improvement of hypoxia for post-crash care patients. Again, this should be something that makes a whole lot of sense, but when we actually looked at how what the testing showed for this, it was actually highly variable, and that's because a lot of people allow not incomplete, erroneous data to be imported into the final data set. So there's a lot of noise here, right? But we looked at EMS responses, right, for patients with the last SAT of greater than 90%, right? Because we wanted to know, did they improve their hypoxia? And so we looked at, again, initial population of all crash patients. And then we said our denominator here is those who had an initial SAT of less than 90. We obviously did not include those less than 24 hours of age. And if they only had a single SpO2 value, we also excluded them as to get a greater clarity in the data set.
Yeah, and that aligns with there's been some discussion on this in more recent measure development projects around this idea of excluding if you don't have the values needed. So I think there's still some discussion to be had on that, but doing this aligns with the existing NEMSQA trauma O3 measure where you have to have two pain scores to see if you've made an improvement in the patient's pain. So this follows that precedent that was set with the pain measure, but I think there is some opportunity for us to discuss how we do this because as you can imagine, like not having two SpO2 values, that could be a quality issue. And if we're excluding those patients, we're not highlighting or elevating that potential opportunity for improvement through the measure. So discussion to be had, but that's the reason why we ended up with this as our exclusion to align with existing measures.
Yeah, and it brings to the bigger discussion too of, are our quality measures, do they exist for the purposes of getting complete documentation, or do our quality measures exist for the betterment of patients, right? And they certainly are not exclusive of one another, but that's kind of where we are. And so we welcome additional thought and feedback from, people as far as this, as we develop additional measures, which would be great. Cool. We can go to number 5. So PCC05 was the tourniquet application for extremity hemorrhage not controlled with direct pressure. Again, this seems like this should be a really easy one, and then we started spiraling on what to do with those that had previously applied by non-transporting ones. So you had a tourniquet put on by police on scene, which was definitely an interesting discussion as we were going through everything. So these were patients with uncontrolled extremity bleeding, which we used E-injury O3 to define for those high-risk serious injuries, or we looked at E-exam 16, where we could say bleeding uncontrolled. And then we looked for the tourniquet application SNOMED code under I forget which data element that was, but yes. So that was what we did with that one. And then our last one is post crash care oh 06. And so this is a little bit of a unique one, and I'm going to explain kind of where this came from and give full credit to Jeff Jarvis for this. So chest decompression procedure performed with indications. So what do we mean by this? So obviously we would love, 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 love to say this person had a pneumothorax or a tension pneumothorax. They should have been decompressed, right? And I don't think any clinician is going to disagree that that's a great quality measure. However, I would ask you, how do you want to measure that with the current data set that we have? And you can sit there and think and be like, yeah, we probably can't measure that very well. If we had trauma registry data that was feeding into this nationally, right, that we could look at, sure, we'd have somewhere to go, but now we don't. So we come up with this next best thing. And this next best thing is kind of the inverse measure, is what Jeff calls it. And so it's not inverse so much that we're flipping numerator and denominator, but it's inverse that we're going to say, so let's actually just look at the ones who had a needle chest decompression performed. Did they at least have clear indications that it was appropriate? Right. And so we're looking at that one to say, if at the very least, if we did it, did we do it to the right people? As opposed to the bigger question, which we all concede we would love to be able to measure, but we weren't able to find appropriate data to do that. So this is that quote inverse measure. And this looks at the denominator of those patients who were transported who had a needle chest decompression performed. And again, remember our initial population is trauma, right? So this is not going to be like a COPD patient or anything like that. And then the numerator is the patients with indication for chest decompression, which we just defined as decreased or absent breath sounds, hypotension, or hypoxemia, right? And so those were the kind of presence that we looked for. And then obviously that procedure is outlined there was e-procedures O3, understanding that chest decompression could be needle or in some places that are allowing finger thoracostomies that could be performed. And so those are the 6 measures that we were able to come up with for this. So was a really fun project to get to talk about post-crash care measures. And we fully acknowledge and have used some of our learnings in post-crash care to help inform some measure maintenance that we're going to perform on our other trauma measures listed here. So trauma oh 01 to trauma 14. But we also just want to emphasize that post-crash care patients are trauma patients, and so that these quality measures absolutely should apply in those patient populations as well. So while we created six specifically for this project, we really have 11 of them total for people to look at for all of their patient care that they're providing. Next slide. There we go. Right. And so we kind of went over a whole lot of different things, right? But our goal here, right, was to try to help define the best system approach using the data that we had available. Right. Obviously, we can't measure safer roads. We struggle to kind of bring in our 911 data into this, right? And so what we have here through NEMSIS, through our partners here, is the best thing that we have now. And I think it gives us a really good launching point to help measure and understand how our system's performing, right? We are really at that intersection of healthcare, public and public health, right? And that we can really help inform the next generation of, hey, we're started here, but this is where we would like to get to. How can we make improvements, right? And we're happy to partner with NEMSIS. We're happy to partner with the Pre-Hospital Guidelines Consortium to help impact and save more lives, right? And then we're happy to help define what those measures will look like so that we can better define our system's performance. But it takes all of us working together, and we're just happy to have hopefully provided one useful piece into that puzzle. And so we'll thank NHTSA for giving us this contract, NEMSIS for our partnership. This would not be possible without you guys. I want to also thank Sheree for keeping us on target with this. I also want to thank Alyssa and Kelly, our two consultants with NEMSQA who did this. My colleague Jeff Jarvis and the entire PCC TEP, we would not have been able to do this. And lastly, Clay and Jeremiah, who have been tremendous friends and supporters of NEMSQA in this project. And it really takes a village, and we have one of the best villages that I've ever had the pleasure of working with. So very excited to be able to share this with you guys. And Sheree, if anything else with you, but we're happy to take questions.
Yep, I think that's perfect.
If anyone, thank you so much for that presentation. Great work as always. To also reiterate from our side of NEMSIS about the partnership, we're thrilled about that as well. Thank you so much for the kind words there. If anybody has a question that they'd like to ask now, feel free to put it into the question and answer section of Zoom, or you can hold up your hand and we'll make it so that you can unmute and ask your question. While people are thinking of their questions and typing into the question and answer, I had something here that I was going to ask. So if someone in an organization who could put these to use feels intimidated by working with quality measurement, QI, and whatnot, what do you tell those people, or what advice do you give them when they're getting started so that they can do it in a manageable way?
Absolutely. So my first thing is start small, right? And start with what's important, right? Look around your community, find out something that you're passionate about. Was there a recent Sentinel event? Was there, recent news headline about something that may not have went well, right? Is there something that your community is uniquely passionate about or uniquely, vulnerable to, right? Find something that's important. And also look around and understand that you're not in this alone, right? Whether it's your medical director, whether it's the hospital system that you work with, or you can look at the broader opportunities that we have across the country. The National Association of EMS Physicians runs quality workshops across the country continuously, and we also have a really awesome 2-day workshop that we host at our annual meeting. If you are a leader of an organization and would want us to come in and kind kind of put on a quality workshop for you, we're always happy to partner and bring our learning there, right? We're happy to kind of sit with leaders from any agency, help you understand how to change your thought process to think about quality so that we can, just help shepherd you along that process because it can be scary and intimidating. But if we can start focusing forward and understanding that quality is not about slapping wrists and making people feel bad about what they didn't do, but making them understand how we can just make improvements with everyone in the future to make a better system, then we're in a going to be in a better place. But yeah, I would say start small and ask for help.
Yeah, that was a great answer, Brian, to highlight, I think, the partnerships and the overlap that would like NEMSIS has the data. We try to take that data and put it into a tool or a resource that can help you measure that care, but just measuring it isn't enough. So, using those resources out there, whether it's the NAMSP, quality and safety, to know what to do with that data in order to improve, you know, it's a
Or
beautiful
or
chain of survival.
or the NEMSQA member networking events that we
Yeah.
do as well, which is just a great time to come in and ask some questions, and we get some really interesting opportunities of people coming in just talking about NEMSQA measures and challenges that they have with it.
The other thing I would point out too in that question of where do you start, and what's important to you and what does your system look like? Like, I mean, probably, a low volume, agency somewhere is not going to pick the tourniquet measure to start or even the chest decompression because those might not really be very high frequency events that you're going to encounter, but those measures may be really useful at like a higher systems level, like at a state level, if you want to look at, appropriateness of care onto really sort of high stakes areas. That may be the place where, say, like a state or regional entity might go. But when you're talking, an EMS agency, um, again, depending on your volume, something like improving hypoxemia is gonna, that's applicable to every trauma patient that you're ever gonna see. So thinking about the attributes of your agency or system and what your goal is might also help steer you in a direction of like, oh my gosh, there's, you know, how many, Brian, did you say? There were like we had six here and then the ones that we had before. So let's just like 12 measures. Where do I
11.
start? Yeah.
Yep. Mhm.
Great. Thank you so. Also, a plug right now for best ways to get in touch with you. I saw the on the website there were some social media links and whatnot. What's the best way to get in contact with you and follow along with your announcements and whatnot?
Wow, you would think that that would have been the last slide in this presentation, and it is not. We're full of thanks for everyone else and not driving to ourselves. That
Okay.
was my fault there. Yeah, we're on all the socials. I mean, obviously you can sorry, oh no, wait, that doesn't work. We don't have to. Actually, does chat work for me as a
Yeah,
speaker?
I'm happy to put that one in there. Is it the NEMSQA.org is the
Yeah, yeah, that's what,
perfect?
yep.
Yeah, let me throw that. I will
Yep.
put a link to that right in the chat here. There you go. And I believe that has a link to your contact information and to all your social media and to all the latest goings on in NEMSQA altogether. Yeah,
Yes, it does. So you'll get
perfect.
all the updates, and we always push out too when we update our do measure maintenance and then update our measures as well. So you can, log in. We'll ask you to create a login when you come in, but you don't necessarily have to join to create the login. We would love you to join as a member. But this way, we at least have your information and we will push it out to you and say, hey, FYI, Trauma O one has now been updated, right? Here's the new one. But we just like to be able to track that. So just know that when you go onto our website, if you're looking for that technical document, you will have to join or at least create a login rather. But you don't have to pay a fee or anything. All of our stuff is available for free. We just want to know who has it so we can tell you when we make changes.
Perfect. Awesome. Thank you so much. Well, thank you for that information. Thank you for the presentation. We really appreciate you being here. We appreciate everybody who came and attended today and participated. This is wonderful information. Like I said, the video will be up and available on our YouTube channel so that you can review this information, share it with anybody that you think might be interested in. If you want to stay in touch with NEMSIS about this and other events and other announcements of things that we have going on, you can also go to our website and our social media. Look up NEMSIS TAC on most of the major social media outlets, and you can follow us from there. Again, thank you so much, everybody, and I hope you have a great rest of your day.
Thanks, everyone.
Thank you.